Let us know about this disease. A 6-year-old boy was brought to the pediatric neurology outpatient department by his parents with complaint of progressive difficulty in walking and frequent falls for the past 2 years. According to the parents, the child has been apparently normal at birth and had attained early developmental milestones with only a milder delay. He achieved head control at 4 months, sat around with support without support at 9 months, and walked independently at around 18 months of age. Soon after he started walking, his parents noticed that he remained clumsy compared with the children of the similar age. He had difficulty in running, was unable to keep up with his peers during the day, and frequently stumbled while walking. Over next few years, the weakness gradually progressed. The parents observed that he found it difficult to climb stairs and often needed to hold the railing or seek the support from adults. They also noticed that he could not jump with both feet off the ground and had increasingly adopted a toe walking pattern. Child had a history of recurrent falls, particularly while running or playing. Falls were sudden, often without any obvious tripping. When asked to rise from the floor, he would first roll over onto his abdomen, assume a 4 point position, and then use his hands to push against his thighs and climb up his own body to stand, suggestive of positive Gover's maneuver. There was no history of sensory symptoms, muscle pain, fasciculations, bowel and bladder disturbances, seizures, or cognitive regression. Birth history was uneventful, and there was no history of perinatal asphyxia or neonatal intensive care admission. Family history revealed that a maternal uncle had experienced progressive weakness since childhood and had become wheelchair bound during adolescence, eventually dying in his early 20s due to respiratory complication. This history raised suspicion of X-linked inheritance disorder. On examination, child was cooperative and alert. His height and weight were appropriate for age. Mild learning difficulties were noted during interaction, although formal cognitive assessment had not been performed. Clinical examination showed cranial nerves normal. There was marked weakness of predominantly involving proximal muscles of both the lower limbs, with hip flexors and extensors being more severely affected than distal muscles. Upper limb was relatively preserved, although mild proximal weakness was present. Inspection revealed enlargement of both the calf muscles, giving them a firm and rubbery consistency on palpation, consistent with pseudohypertrophy. The child exhibited lumbar lordosis and waddling gait. He walked on his toes and had difficulty walking on heels. Gover's maneuver was strongly positive. Muscle bulk in the proximal thigh muscles was reduced. Deep tendon reflexes were diminished at the knee but preserved at the ankle and the upper limbs. Sensor examination was normal. Plantar response were flexors bilaterally. Routine laboratory investigations revealed marked elevated serum creatinine kinase levels of approximately 18,500. Liver transplant liver transaminases were also elevated, although there was no evidence of intrinsic liver disease. Nerve conduction studies were normal, whereas electromyography demonstrated myopathic pattern characterized by shorter duration, lower amplitude motor unit potentials with early recruitment. Given the clinical suspicion of Duchenne's muscular dystrophy, molecular genetic testing for mutations in the dystrophin gene were performed. Multiplex ligation dependent probe amplification (MLPA) identified a deletion involving exon of 45 to 50 of dystrophin gene, confirming the diagnosis of Duchenne's muscular dystrophy. Muscle biopsy was not required because of definitive genetic diagnosis. Cardiac evaluation, including electrocardiography and echocardiography, showed no evidence of cardiomyopathy at presentation. Pulmonary function test demonstrated preserved respiratory function. Family was counseled regarding the progressive nature of the disease and the need for long-term multidisciplinary care. The child was initiated on a daily physiotherapy with emphasis on stretching exercises for the heel cords, hip flexors, iliotibial bands to prevent the contractures. Night ankle splints were prescribed. Oral corticosteroid therapy with prednisolone was started after counseling regarding benefit and potential adverse effects. Family was advised regarding regular follow-up with neurology, cardiology, pulmonology, physiotherapy and rehabilitation services. At follow-up over the next few years, child demonstrated gradual progression of weakness, necessitating the use of assistive devices of ambulation. Continued multidisciplinary management was planned to optimize functional status, monitor for cardiopulmonary complications, and improve the quality of life